Our subject today about pancreatitis. Alcohol ingestion is associated with up to 60 to 70% of cases of chronic pancreatitis. In addition, ductal obstruction, autoimmune disease, tropical disease, and an association with systemic illness such as scleroderma and hypertriglyceridemia have been described. Recently, a new insight has been gained into the genetic and the molecular base associated with hereditary form of chronic pancreatitis. The most widely accepted system for etiological classification of chronic pancreatitis is the TGAR-O system, which categorizes risk factors according to mechanisms and prevalence. Please search for this TGAR-O system and prepare it for the next face-to-face session. Morphological changes associated with chronic pancreatitis include both ductal and parenchymal changes. Pancreatic ducts may become dilated, irregular or restricted. The glandular tissue itself is often characterized by irregular and patchy replacement of normal acinar cell architecture with fibrosis. Hypotheses to explain the mechanisms underlying the pathogenesis of chronic pancreatitis focus on the role of oxidative stress, toxic metabolite causes, and obstructive causes. The oxidative stress hypothesis attributes pancreatic damage to reflux or the bile rich in reactive oxidative byproduct, while the toxic metabolic theory involves direct damage to pancreatic acinar cell from noxious stimuli such as alcohol. The obstructive theory, on the other hand, attributes the majority of injury to pancreatic ductal injury resulting from obstruction related to increased lysogenicity and later in turn caused by either genetic or environmental exposure, example alcohol. Finally, the necrosis fibrosis hypothesis describe chronic pancreatitis as a continuum that is initiated by an attack of acute pancreatitis. The subsequent injury and remodeling lead to pancreatic fibrosis. The hallmark features of chronic pancreatitis are abdominal pain and pancreatic insufficiency. The possibility of chronic pancreatitis should be entertained in any patient with symptoms of chronic abdominal pain, especially if this pain is postprandial and triggered by high fat or protein-rich meal. In addition to presence of predisposing etiologic factors according to the Tiger-O classification. Abdominal pain is classically described as epigastric, often with radiation to the back. Pain is often unrelenting and difficult to treat. Pain may be postprandial associated with nausea and vomiting. We can classify type of pain into type A and type B. Type A, which is early in the disease course, occurring in discrete episodes. Type B pain, as the disease progresses, pain becomes continuous. The pattern and course of pain symptoms is highly variable among patients with chronic pancreatitis. As regards pancreatic insufficiency, clinically significant protein malabsorption and fat malabsorption doesn't occur unless uh, over 90% of the pancreatic function is lost. Typically, steatorrhea precedes the onset of protein malabsorption. Fat malabsorption can manifest clinically as poorly formed, greasy, malodorous stool. Although absorption of fat-soluble vitamins may be reduced, clinically significant vitamin deficiency is rarely reported. Pancreatic endocrine insufficiency, presenting as diabetes, is distinctly late. A patient with chronic calcific pancreatitis or with family history of diabetes have been observed to be at increased risk of developing this complication. Though diabetes associated with chronic pancreatitis is insulin requiring, these patients are also at increased risk of hypoglycemia due to impaired glucagon synthesis resulting from pancreatic alpha cell destruction. Laboratory finding in a case suspected of chronic pancreatitis, first of all, amylase and lipase. In contrast to acute pancreatitis, in which amylase and lipase, especially if with level more than threefold upper limit of normal, is one of the diagnostic criteria. Amylase here in chronic pancreatitis is just elevated in acute pain episode early in the disease, but becoming normal or even low in patients with moderate to severe chronic pancreatitis. The second test is fecal pancreatic elastase 1, which is a test of exocrine pancreatic function. This test is assessed by ELISA on stool specimen. A level less than 100 microgram per gram of stool correlate with severe exocrine pancreatic insufficiency. The widespread availability of this test has reduced the need for 24-hour fecal fat quantitation as a means of evaluating steatorrhea. Hemoglobin A1C is another test to investigate glucose intolerance in a case of suspected endocrine pancreatic dysfunction. Markers of autoimmune chronic pancreatitis, including immunoglobulin G4, rheumatoid factor, and an anti-nuclear antibody to assess a case suspected of of autoimmune pancreatitis. Evaluation of liver function test. An elevation of liver function test may signal compression of pancreatic portion of the bile duct from fibrosis, edema, or tumor development. Imaging studies. First of all, plain abdominal radiography may reveal calcification within the pancreas, common in alcoholic and tropical pancreatitis. Transabdominal ultrasound has been associated with low sensitivity in diagnosing chronic pancreatitis, except in patients with severe disease. Contrast-enhanced computer tomography (CT) and magnetic resonance imaging (MRI) offer enhanced visualization of the pancreas and adjoining structure. Contrast-enhanced CT allow evaluation of the parenchymal architecture. Complications such as pseudocyst, pseudoaneurysm, and venous thrombosis are well characterized by CT. MRI technology, especially magnetic resonance cholangiopancreatography (MRCP), has the ability to visualize fluid-filled structure, allowing a characterization of the pancreatic duct. Endoscopic criteria for the diagnosis of chronic pancreatitis include parenchymal features, atrophy, hyperechoic foci, stranding, cyst, and lobularity, and ductal features like narrowing, dilatation, irregularity, and calculi, side branch dilatation, and hyperechoic wall. The diagnosis usually requires identification of 5 or more of 11 criteria. Endoscopic ultrasound (EUS) appears to be particularly beneficial when evaluating cystic lesion believed to be arising in the backdrop of chronic pancreatitis, as well as examining parenchyma when presence of disease is equivocal. ERCP, while providing an excellent view of the pancreatic mean duct and side branches, ERCP also offered the possibility of the therapeutic intervention. However, given the associated risk of inducing acute pancreatitis, ERCP is generally reserved for situations in which intervention is likely. Special tests in diagnosis of chronic pancreatitis. One of them is gene testing in cases suspected with a suspected hereditary form of chronic pancreatitis. The other is pancreatic function testing. Sampling of secretin hormone-stimulated pancreatic fluid from duodenal aspirate theoretically allow detection of impaired pancreatic function prior to the onset of structural abnormalities. The most widespread technique consists of aspiration of duodenal juice through a dual lumen drilling tube every 15 minutes for a total of 16 minutes. Following administration of secretin hormone, a peak bicarbonate concentration less than 18 milliequivalent per liter is consistent with a diagnosis of chronic pancreatitis. More recently, endoscopic pancreatic function testing has emerged as a specialized center as an alternative modality for direct sampling of duodenal aspirate. Furthermore, breast testing has recently been shown to be equivalent to fecal fat measurement and may allow a non-invasive means of monitoring therapy. Lastly, or recently, a 13-carbon mixed triglyceride breast test has been evaluated as a potential tool for evaluating the effect of enzyme therapy on fat digestion in chronic pancreatitis. The chronic pain associated with chronic pancreatitis should be differentiated from any other causes of chronic abdominal pain, like peptic ulcer disease, inflammatory bowel disease, gastric dysmotility and irritable bowel syndrome, psychogenic or factitious drug-seeking disorder. The maldigestion associated with chronic pancreatitis also must be distinguished from other malabsorptive disorders such as carbohydrate malabsorption and celiac disease. It may help to ask about the history of sticky or greasy stool as well as the presence of oil drops separating from the main stool. These are features often associated with significant steatorrhea and strongly suggest the diagnosis of pancreatic insufficiency. Complications of chronic pancreatitis include pseudocyst, biliary duct or ductal obstruction, pancreatic ascites or pleural effusion, splenic vein thrombosis, pancreatic fistula, pseudoaneurysm, and an increased risk of pancreatic cancer. Treatment should be aimed at analgesia, reducing inflammation, and overcoming intrapancreatic pressure. Lifestyle modification, including cessation of alcohol, consumption of a smaller low-fat meal, and quitting smoking. Other therapy should be directed toward the treatment of symptoms and guided by underlying suspected cause. The mechanism causing pain in the pancreatitis include recurrent tissue inflammation, necrosis, pancreatic ductal hypertension, increased interstitial fluid pressure, pancreatic ischemia, and fibrotic enhancement of sensory nerve. Analgesics should be administered in conjunction with pain specialists. Patients should be asked to maintain a daily log of pain while receiving both non-narcotic and narcotic analgesics. Inflammation can be reduced by smoking cessation, trial of total parenteral nutrition or enteral feeding, surgery for obstructive pancreatitis, and corticosteroid for autoimmune chronic pancreatitis. Methods of reducing pancreatic pressure include suppression of secretion via administration of proton pump inhibitors, pancreatic enzymes, and potentially octreotides. If autoimmune pancreatitis is suspected, therapy with corticosteroid is beneficial. Obstruction. In the case of ductal stenosis, endoscopic clearance, surgical therapy, or extracorporeal shockwave lithotripsy may be attempted though evidence for individual treatment modality is limited. Symptomatic pseudocysts may be drained percutaneously using endoscopic ultrasound or surgically. Surgical options for chronic pancreatitis include lateral pancreaticojejunostomy for decompression of a dilated main duct, removal of localized disease by either a Whipple procedure or a tail resection, and finally total pancreatectomy. In case of severe pain not responding to analgesics, modification of neurotransmission may occur using endoscopic ultrasound guided celiac plexus block or bilateral thoracoscopic splanchnictomy measures or transcranial magnetic stimulation. On the other hand, exocrine insufficiency can be managed by pancreatic enzyme supplementation to help digesting protein and lipid products in patients with severe chronic pancreatitis. Use of this enzyme, in addition, may relieve pain through reducing duodenal cholecystokinin release. Typically, this enzyme should be given with each meal. The natural history of chronic pancreatitis remains ill-defined. in part because of its highly variable nature. The relationship between etiologic factors, genetic predisposition, and pace of disease progression require further clarification. Modifiable risk factors need to be identified and treated. It appears that discontinuance of alcohol, cessation of smoking, and early administration of corticosteroid in autoimmune disease may affect the natural history and the prognosis of the disease. Before goodbye, please be ready with your question in the next face-to-face session.